Good morning. It's my pleasure to introduce our guest speaker. It's really a great pleasure and honor to introduce Dr. Schauer. I think many of you know Dr. Schauer is from Texas. If I'm not mistaken, went to Texas A&M, and then Baylor College of Medicine, and came here for his surgery residency. He was worked with and mentored, with Dr. Srinick, Dr. Ramos, Callie and Lum, finished in 95, and following residency he went to Duke, where he did minimally invasive surgery bariatric fellowship, and then joined Pittsburgh as the chief of bariatric surgery. In Phil's career, he's been an innovator in all aspects of minimally invasive in bariatric surgery. He's been instrumental in new concepts with respect to both MIS and bariatric metabolic surgery, and also is active with respect to patient safety and improving systems of care. He has over 200 papers. He's in all of the prestigious surgical associations, trained more than 20 fellows, and is past president of the American Society of Metabolic and Bariatric Surgery. So, Dr. Schauer, welcome. Welcome back.
Thanks, Ronnie. Well, I just can't tell you what a thrill it is to be back. Some 20 years, almost 20 years since I left this great institution. For all you youngsters out there, I can tell you from a career point of view, there's nothing more thrilling than going back to the place where you started, where you got your roots, and be able to talk intelligently to your peers and to your mentors. And it's such a thrill. It's great seeing some old friends. Tony Cruz, Wade Rogers, Carlos Pestana, Arthur McPhee, Raul Ramos, Wayne Schlesinger, Ken Srinick. I mean, these are the guys that trained me. And for better or worse, guys, I'm a product of your labor, okay? Too late, you got to claim me, okay? But it is a thrill to be here, and I'm so excited to be able to talk to you about kind of an interesting topic. I'm currently at the Cleveland Clinic, which is a great place, and you see here, this is one of our actually new buildings. Supposedly, it's the largest dedicated cardiovascular center in the world, and the Cleveland Clinic is one of the top-rated heart centers in the world. And it's funny, I kid Steve Nissen. Steve is one of the world-famous cardiologists, and he always goes around saying he's going to put the cardiac surgeons out of business with all the statins and stents and everything. And I tell Steve Nissen, I'm going to put him out of business, okay? Because we're going to take metabolic surgery and put the cardiologists out of business. And hopefully I'll be able to explain what I mean with some of the data here. You got to do all this. We collaborate a lot with industry as well as government organizations, so this is my disclosure statement. Before I get into the meat of the talk, I just want to share with you about some fond memories of being here at UT Health Science Center San Antonio. In fact, this very room brings back memories. It's the same room. We had grand rounds 25 years ago. Remember, in the back row, sleeping, trying to stay awake, you know.
Printing our slides out.
Printing our slides out, yeah, taking... Yes, and Dr. Al's little photography room and taking pictures, and great memories. But another great memory. There's a wall of fame or a wall of shame or something where the graduates are. And I'm going to show you. There's a graduate. I can't believe this guy made it through the program. Here he is, surgery man. Now there's another one also. There's a black feather for this guy, and I won't really mention what it was about. But so I was here in 86 to 93. One major claim of distinction I had, I was the only graduate, I think, that figured out a way to cram 5 years of training into 7. Yeah, I crammed it all into 7 years. Actually, I took a little, rerouted for a couple years into research. I didn't know what I wanted to do. And for all of you youngsters out there that don't know what you want to do, there's hope. I had no clue. I liked everything. Spent a couple years in transplant. I realized that wasn't for me. But you never know. You never know what's going to come along. And for me, I a couple things that I never expected happened. The advent of laparoscopy and then this thing about metabolic surgery completely changed my career track for the better. It's been a very exciting journey. So for all of you that are not quite sure what you want to do, hey, just hang out and grab onto something that looks interesting. You don't have to have your entire career laid out before you as an intern, and I certainly didn't. This is my lovely wife, and actually she was my girlfriend at the time. She's the reason why I survived residency, and she has. It's been a wonderful ride, and I'm so lucky. A few years later, I married her, and the rest is history. We have 4 lovely kids, and aside from all the academic accomplishments I've had, to me, this is my most important product and contribution to the world, are my kids and my lovely wife. So I did want to acknowledge them. So, now, it might be appropriate, and I'm talking about what the next big thing is. Well, what was the last big thing? Well, when I was a resident, the big thing was peptic ulcer surgery. I mean, in fact, there are generations of surgeons that really cut their teeth on learning how to operate with peptic ulcer surgery. This is a really important study that came out of this institution in 2001 that basically cataloged the demise of peptic ulcer surgery. And the red bar there are my years in residency training. 1986, and that was, look at that, it's the most rapid period of demise of peptic ulcer surgery. I'm not sure if it had anything to do with that, Ken. An amazing ride, and, I remember when I was a resident, there were people talking, well, general surgery is dying. I mean, all these medications, H2 blockers, PPIs, and then, heaven forbid, antibiotics are taking away this glorious surgical disease, and then people are talking about, lithotripters for gallstones. What's going to be left? Nothing's going to be left in general surgery. But you never know. You never know what may happen. So what has happened, well, during this rapid demise of peptic ulcer surgery, another opportunity was developing. Well, actually, here's some of the other studies that also cataloged the demise. You can see all these studies, just very rapid demise of peptic ulcer surgery. But the roots of peptic ulcer surgery blossomed into a whole new field. And what will fill the void? Will general surgery wither away? And the answer, of course not. Because what happened? Well, during this exact time period, as peptic ulcer surgery was dying and drugs were developed, a new problem was developing. And this is the obesity epidemic and the diabetes epidemic, the twin epidemics of our time. And you can see that the slides that are 2000, the maps are 2001, they're now almost red. Not because we're all Republicans, but because we're all severely obese. In most states, and Texas is one of the leaders, we have a big problem with obesity and diabetes, and most people think that obesity is a major factor in the development of type 2 diabetes. Very debilitating disease. I call this the obesity iceberg. This is a famous cryo building at the Cleveland Clinic. Gives you a sense. It's a little bit dated. Actually, the U.S. population now is over 300 million. And if you can look at this tiered structure, 2/3 of us are not normal weight. Only 1/3 of Americans are actually normal body weight. Most of us are overweight, and some 15 million or so are severely obese. So it's a tremendous problem. Complex disease. If anybody thinks that obesity is just simply somebody eating too much and not exercising enough, you got another thing coming. It's a very complex interaction between the environment and genes. Obesity itself is thought to be a chronic inflammatory state that gives rise to all of these subconditions: insulin resistance, atherogenic dyslipidemia, pro-inflammatory state, autonomic dysfunction, elevation in blood pressure that leads to lots of big problems down the road, mainly cardiovascular disease, microvascular disease. So it's a big problem, very complex. And this slide just really doesn't do justice to the complexity of this problem. People talk about the metabolic syndrome. which is this cluster of conditions that appear to be all linked by this thing called central obesity, visceral obesity, and insulin resistance. It used to be that just hypertension, diabetes, dyslipidemia were on that list. Now you can add OSA, which is obstructive sleep apnea. You can add polycystic ovarian syndrome and NASH, non-alcoholic steatohepatitis. They all appear to be centrally linked by insulin resistance and central obesity, and are big, big health problems. And there's even more. We call this the metabolic woman, and you can see here that virtually every organ system is adversely affected by obesity. This is just a partial list. There's some 75 to 100 different disorders that are thought to be closely linked to obesity, particularly central obesity. But I want to focus on, I think, one of the most preeminent problems is type 2 diabetes. I'm so pleased we have Dr. DeFronzo. Where's Ralph? In the audience, one of the world's foremost authorities. I don't know if you folks realize what gem you have here in Dr. DeFronzo and his department. But this is a phenomenal problem affecting more than 20 million Americans, and there's 54 million who have prediabetes. It's a quintessential medical disease. Now, remind you, this is a medical problem that has always been treated medically. This may be a chance for us surgeons to get back, right? Get some territory back, right? They took away peptic ulcer surgery. We're going to get back at them, right? So, very difficult problem. Look at this. All the complications of type 2 diabetes. This is just a partial list. Increased mortality, tremendous disability, metabolic complications, blindness, amputation, renal failure, heart disease, stroke, again, affecting virtually every organ system. Very debilitating problem, and it's getting bigger, and as has been mentioned before, we have a tsunami coming our way with this disease and others. So let's talk about the natural history. I think it's important to get a better understanding of this condition. Type 2 diabetes is basically a state of hyperglycemia. But we know now that at the time of diagnosis, which is right here, when you see elevated blood sugar, we know that the disease state has actually been existing for probably a decade or so before that, so-called prediabetes or impaired glucose tolerance. And this is a state of profound insulin resistance. And this is a state where the beta cell is overproducing insulin to compensate in an attempt to keep the blood sugar as normal as possible. But what happens over time, probably due to a number of factors, perhaps such as glucotoxicity, lipotoxicity, the beta cells fail. And it's thought that type 2 diabetes is really a disease of beta cell failure. And unfortunately, this drags out over a period of time where the beta cell cannot keep up with the needed production of insulin. And this ultimately results in development of these dreaded complications, macrovascular and microvascular changes, such that ultimately patients that have this condition, they die about 10 to 15 years shorter than they should. And before they die, they're going to have major cardiovascular complications. And Ralph may argue with me about this, but despite tremendous advances in medical therapy, we really haven't altered the natural progression of the disease that much. We've probably slowed it down a little bit, but we really haven't made a huge impact. And maybe Ralph will opine about that later. Another way to look at it is here. You can see with the treatment on the bottom, starting with lifestyle therapy, monotherapy, combined oral therapy, and insulin. But you see this natural progression of the disease, even despite medical therapy. That's because it's so hard to keep these folks in good glycemic control. And we're not just treating the blood sugar, we're treating the other problems, the hypertension, dyslipidemia, and so forth. So here's the ABCs of diabetes management. This has been sort of the medical treatment algorithm for several decades. You treat the blood sugar, you try to keep the A1C below 7, which, by the way, is not normal. 6 is normal. It's so hard to get to 7. Getting to 6 is almost impossible. Keep the blood pressure under good control, control the lipids, antiplatelet therapy is needed, smoking cessation. This is a standard therapy for treating diabetes. And look what's happened over the past 100 years. Look at all the drugs that have been introduced. You would think with all these phenomenal drugs, we would be able to have a huge impact on this disease state. But unfortunately, it still remains a big, big problem. Here's a standard American diabetes algorithm. This is how endocrinologists treat this disease. I'm a surgeon. Think simply. This is complex. Okay? Going through this maze, you got 4 or 5 drugs, get them to exercise. I mean, how can any patient, let alone doctor, keep up with this strategy? And basically, to summarize the medical treatment, it's basically a strategy of polypharmacy. And this is came out of the New York Times a few years ago. This is data from John Buse, who was a past president of the ADA. This is just an example of one patient who had diabetes and the myriad of metabolic disease. These are the drugs that she was taking daily. 15 types of oral medications, 7 to 10 injections per day, 4 finger pricks per day, costing $1,800 a month. This is the current medical strategy for treating that disease. Now, I'm exaggerating a bit. This is not every patient, but this is the ultimate epitome of medical medicine. Who can keep up with all these medications, let alone the cost? And how effective is it? This is a little bit dated data. 2004, this is NHANES data. It looked at a population of 400 patients with type 2 diabetes, and this is how effective the community doctors were at getting patients to an A1C of 7% or less. Only 37% actually met target. So most of these folks were out of control. And then when you add to that those that met all 3 targets of blood sugar, blood pressure, and cholesterol, only 7% were actually at the ADA target thresholds. So if you ask me, that's not very effective. And now, you may argue that endocrinologists who are trained can do much better than that. Well, here's the data from the Cleveland Clinic Diabetes Center. We have some really good endocrinologists. In fact, U.S. News rated us the 5th best endocrinology department in the country. If you believe that. They're very good. But my point is, look, these are the last several years. Only 34%. Of course, they get the more difficult patients. Obviously, they're referred to a tertiary care center. But only 34% were actually at target. And a lot of the patients were way out of control, 24%. And they also struggle with LDL and blood pressure control. And they're doing much better than average. The NCQA is sort of a national average target, doing much better than average. But it just goes to show you, even in the hands of very experienced endocrinologists, it's difficult to manage this disease because there's no single drug or drugs that are that effective. So it's time to consider wiping the slate. Let's consider a completely alternative strategy. Okay? Here it is. Try something completely different. Surgery. Okay? Bariatric surgery. These operations shown here were initially developed in the 1950s, and some of them have evolved from their forebears, but they were designed for heavy people to lose weight. And we've discovered over the years that they can be extremely effective in improving diabetes, partly because of weight loss. We know that weight loss improves insulin resistance, but there may be other factors too, which we'll get into in a little bit. You can divide these operations into sort of, roughly speaking, different categories. The first 2 are procedures that affect mainly the stomach. We call them restrictive operations. That's just a placeholder name. Don't pay too much attention because it really means nothing physiologically. But these operations, we think, work because they, in some way, we don't have the mechanisms worked out, they reduce appetite and they enhance satiety by reducing the gastric compartment, either with a band at the top or the old VBG operation by reducing the compartment of the stomach to sort of accentuate this sense of satiety. The operations at the bottom, fairly radical procedures that, although they reduce the stomach capacity a bit, the biliopancreatic diversion and the duodenal switch, they involve hemigastrectomies. They really involve dramatic bypasses of the GI tract, such that the upper GI tract is hooked in to the terminal ileum creating a very short common channel, 75 to 100 centimeters. So that common channel, where you have the admixture of the biliopancreatic digestive enzymes and the alimentary limb, which carries the food material, that common channel is where all the absorption, or most absorption, occurs. So by decreasing the length of that common channel, you can control absorption of calories and nutrients very effectively. Those operations are the most effective bariatric procedures, but unfortunately they're not very specific to reducing absorption of calories. A number of important nutrients also are not absorbed very well. Hence, a number of these folks will get into trouble with metabolic complications and nutrient deficiencies, particularly fat-soluble vitamin deficiencies. Now, these two procedures here are major improvements on the earlier operations, the jejunal ileal bypass, which basically is an operation that bypassed the entire GI tract. And that operation became extinct a number of years ago. But these are nevertheless very effective operations, but only about 2% of all bariatric procedures today consist of these procedures. Now, the one in the middle is the Roux-en-Y gastric bypass. Now, that procedure is thought to be a combination, okay? It does incorporate some of the principles of, gastric volume reduction, gastric restriction, as well as some of the principles of bypass surgery. But in this case, unlike the other lower procedures, we're talking about just a foregut bypass. Most of the GI tract remains intact, so it's got a very long common channel. So we're only bypassing stomach, duodenum, small portion of jejunum. So this procedure incorporates a little bit of both principles and has a much, much lower rate of metabolic sequelae. And hence, for this reason, this operation has really been the dominant procedure, at least in North America, for the past couple decades. So these are the tools that we have to work with. I very superficially went over the mechanisms of action because, quite honestly, we don't really know how they work. Now, I also hasten to add that in addition to these procedures, there's lots of new operations that are being developed, and a lot of these are even less invasive procedures. Many of these are done endoscopically without any external scars, and we're talking about, I think, within the next 3 to 5 years, outpatient procedures performed not in the OR but in the endoscopy suite, and you can imagine the advantages of those in terms of cost and ability to improve access. Now, one of the reasons why these operations, of course, had such a dramatic increase in usage and popularity in the 90s and over the last decade is the paradigm shift from open surgery to laparoscopic. And this is one of the first things that sort of grabbed me in my academic career, this sort of fascinating major paradigm shift in surgery. You see on the far right, we had to make big incisions, long incisions, very deep. It turns out that the access incision was the most morbid part of the operation. What we did on the inside really had fairly minimal impact. And the switch to the laparoscopic approach has really dramatically changed the game, reducing major morbidity and mortality, not only in bariatric surgery, but in many other areas so dramatically. Now, let's talk about the story of these operations in diabetes. So it's interesting, although it really came to light in the 90s, if you go back far enough in the surgical literature, you realize that somebody else thought of this a lot earlier, right? And that was when I was a resident, you never claimed you had a new idea, because if you go back in the literature, you'll find that somebody else thought of it before you. Right, Carlos? So in 1955, this is a publication, SGO, and this is the peak of the peptic ulcer surgery era. These folks in Brooklyn, New York, published this subtotal gastrectomy for peptic ulcer disease and discovered that patients that had diabetes who had this procedure got better, resolved. Nobody cared. Nobody listened. It sort of got buried in the literature and wasn't really resurrected until the 90s when people started looking at this more seriously. And so we see in the early to mid-90s, you start seeing reports in major surgical journals. And Walter Porridge, I think, is the one that gets credit for really starting this revolution when he published several papers preceding this, but this is the most famous. Can you imagine a title? Who would have thought it? an operation proved to be the most effective therapy for adult onset diabetes. Gotta love it, don't you? Gotta love that title. Annals of Surgery, 1995, went completely ignored by most of the world, okay, except for maybe a few surgeons. The endocrine community completely ignored the study. A few other studies were published, and the momentum started picking up. And I think a lot of that was because bariatric surgery was picking up because of laparoscopy, and people started becoming interested in this phenomenon. I became interested in this when I was in Pittsburgh. This is one of our earlier studies. And basically this study, what its main contribution was is it corroborated what Walter Porres was doing. Almost the exact same results. We had 200 patients who were severely obese, either diabetes or impaired fasting glucose. Average BMI is 50. We tracked their diabetes remission before and up to 4 or 5 years after surgery. These folks lost a lot of weight. That was nothing new. But what was interesting was that about 80% of them who had diabetes returned to a normal fasting blood sugar and normal A1C, 6% or less. And it turns out that, not surprisingly, those that had fairly early disease, those that had disease that wasn't so severe, where the A1Cs were, not too bad off, 7-8%, and those that lost the most weight were the ones that were likely going to reach remission. And since then, there's been dozens and dozens of studies. Here's a nice meta-analysis published a couple years ago, 2-3 years ago, looking at 20 of the best studies, over 4,000 patients, looking at a variety of different procedures, gastric banding, gastroplasty, gastric bypass, and those malabsorption operations. Showing here is the excess body weight loss in terms of percent of excess body weight. So most of these, the patients lose at least half of their excess weight, and many of them, see on the far right, they lose a majority of their excess weight. But the next row shows you the resolution overall in diabetes. And granted, have to admit that the quality of some of these studies is a bit marginal. The way surgeons defined remission or resolution was not uniform. These are all retrospective studies. The percent follow-up was not well controlled. So our critics in endocrinology and the medical world are rightly justified pointing out that there are definitely some limitations. But the one thing that is quite remarkable is that 100% of these studies show the same thing. They show not just a slight benefit, but a very dramatic treatment effect of these procedures. Very, very dramatic. Now, it's not just about blood sugar. When you're treating diabetes, as I mentioned, you've got to treat the other parameters, and the cardiologist would argue it's more important to keep their blood pressure in control and their lipids in control than it is to keep their blood sugar. So how do these procedures affect these other endpoints? And it turns out quite effective. This is one study from our group in Pittsburgh where we looked at 70 patients, and we looked at all of these metabolic parameters. And in this study, these folks were quite heavy. The average BMI was 56 at the start. But we looked at the changes, and this is like 14 months or so after the procedure, gastric bypass, the effect on systolic, diastolic blood pressure, fasting glucose, cholesterol, triglycerides, so on and so forth. And you can see these very significant improvements. And since then, numerous studies have pointed out the change in cardiovascular risk factors after bariatric surgery. This is a review paper our group just published last year in the American Journal of Cardiology, looking at some 52 studies that report outcomes. Again, most of these are observational data, retrospective studies, but report outcomes, not just in glycemic control, but these other parameters. And if you look here, you see very consistent improvement in systolic and diastolic blood pressure, fasting plasma glucose and A1C improve in these studies, the lipid profile, cholesterol, LDL, triglycerides all improve, and even HDL, which is very difficult to manage pharmacologically, has been shown to be consistently improved after virtually all of these procedures. And even other markers such as Framingham risk have been shown to improve, and the C-reactive protein chart looks exactly the same as this, where you see very significant reduction in C-reactive protein, which is a good marker of chronic inflammation and cardiovascular risk. And one of these other, I just want to briefly take a sidebar here, one of these other commonly associated problems with metabolic disease is non-alcoholic fatty liver disease. Just last week at the American Surgical, Ron Busuttil's famous liver transplant surgeon gave an address and pointed out that the number 2 cause or factor for liver transplants these days is fatty liver disease. In the next 5 years, it will be the number 1. He said there's going to be 1 million people who would qualify for a liver transplant because of fatty liver disease. So this is a study that we performed showing 70 patients. These are pretty high-risk folks who all had bariatric surgery and fatty liver disease, and some of them fairly extensive disease. About 5% actually had frank cirrhosis. And dramatic improvement in histology. We did biopsies before and after. On the far right is a classic biopsy of NASH, and you can see the steatosis, the fat cells. I don't think you need to be a pathologist to appreciate the pathology here, as well as bridging fibrosis and inflammation. And on the right, that's the left. On the right is the same patient 9 months later with almost normal-looking liver. So pretty dramatic changes. We saw about 40% of the patients had a complete reversal of their NASH after surgery. Now, a controversial area that I just touch upon just a minute is this notion about body mass index and its role as a determinant for who actually should get surgery. And arbitrarily for the past 30 years, BMI of 35 has been designated as threshold for severe obesity. Above that, surgery would be justified. Below that, surgery would not be justified. It's somewhat ludicrous. BMI of 34.5, someone is not eligible for surgery. So what's happened over the several years, a number of studies have been to accumulate, if these operations are effective for the severely obese, well, why wouldn't they be effective for folks that maybe are not so severely obese but still have a huge metabolic burden? So what we're beginning to see, and this is, I'll just refer you to a review paper, some 16 or so studies. They're all very small, retrospective studies with ends between 20 and 100, with a lot of different procedures, but they all show the same thing that suggests that these operations, particularly folks that have a major metabolic burden, are also effective in folks with BMI less than 35, even as low as 25 or so. So definitely is worth further investigation. Now, of course, the most important, and I've given you a lot of data, blood pressure and blood sugar, and these are all considered soft endpoints. These are sort of surrogate markers. What doctors and patients are really interested in is how do these operations affect clinical outcomes, what I talked about earlier, the heart attacks, strokes, deaths, and so forth. So we've seen accumulation of studies over the years that are looking into this, and probably the most important and most famous is the Swedish obesity subject study. This is an important study that started in the late 1980s in Sweden. The unique thing about Sweden is they have a closed healthcare system, so they have a tremendous ability to follow patients. So this data was just published in JAMA in January, and you can see that they've got follow-up out to 20 years. And in this study, you can see the top group there is the control group. These are patients that were treated. They all had obesity, a BMI of 35 or greater. The average BMI was close to 50, but they were treated with sort of community standard treatment for obesity. The others represent surgical treatment, gastric banding, vertical banded gastroplasty, and gastric bypass. Now, the amazing thing is Dr. Sjostrom and his colleagues was able to achieve greater than 90% follow-up at 20 years, which is an amazing accomplishment. It's so hard to keep people in studies. And I can tell you there are very few medical weight loss studies that have this kind of follow-up beyond 2 or 3 years. Okay, so this is phenomenal. Now, important to note, this is not a randomized controlled trial. This is a matched cohort study. The groups were matched, about 18 different demographic features, age, body mass index, comorbidity profile, so on and so forth. So it's about as good as you can get without having a randomized controlled trial. Now, the study is still criticized by some people because it is not a pure RCT, but it's about as close as you can get. And in addition to showing superior weight loss that is sustained, I mean, no one can argue that this weight loss is not sustained. And while there is some weight regain from the nadir, which occurs about 1 to 2 years, it happens for all these procedures, most of the weight loss is sustained out to 20 years, which is pretty impressive. There's nothing in the medical world that has shown any strategy, exercise, diet, or drugs to show sustainability of a medical treatment. And this is the data published in January, the data on fatal cardiovascular events between the control group and the surgical group, and total cardiovascular events. I don't think you need a lesson in epidemiology to be able to appreciate the major differences there. You can see that around year 5 or 6, the curves separate, favoring surgery. So a significant reduction in fatal cardiovascular events, and all cardiovascular events occurred in the surgical group. And then the mortality, this was actually published a few years ago, overall, all-cause mortality, which is probably the most important clinical factor to look at, favored surgery, and this is at the 16-year follow-up. You can see about close to 30% reduction in overall all-cause mortality. That's a lot. For anything to cause a 30% reduction, just for a comparison, some people think that coronary artery bypass surgery reduces mortality. It doesn't. It's very good palliation. Are there any heart surgeons in the room? Don't want to piss anybody off. Dr. Calhoun in the room. It's very good at palliating chest pain, and for those that have critical LAD, it actually shows a slight mortality benefit. But it doesn't show this. Okay? So, pretty remarkable. And here's the other studies that support the SOS. Again, with varying degrees of quality. None of these are randomized controlled studies. It's 8 or 10 or so studies, but they all show, the far right column, at various degrees of follow-up, significant mortality reduction. They all say the same thing. Okay. And again, just for comparative mortality, the mortality risk of the operation versus the mortality benefit. When you compare the mortality risk of bariatric surgery, which is now about 0.28%, and by the way, that's the mortality risk of cholecystectomy nationally. It's the same risk as hip replacement. It's 1/10 the risk of coronary artery bypass surgery. Some of you may think I'm picking on heart bypass surgery, and I am. Okay? Because it's overrated. Okay? When you consider the overall benefit, that's 10 times the risk and much less the long-term benefit. So, a sidebar, and I wish I could spend more time on this subject, because this is what's really fascinating. How does bariatric surgery resolve the metabolic syndrome? This is a great source of intense research, because we can figure out how these operations work. We can develop better operations, or maybe even a magic pill, Ralph, okay, and put us surgeons out of business, right? Is it just weight loss? Obviously, weight loss plays a role. Okay, everybody knows tons of studies showing reducing weight by any means, diet, exercise, surgery, improves insulin resistance and dramatically improves diabetes. But there's some data, and I'm not going to be able to do this topic justice today because it would really take more time, but there's some data suggesting that some of these operations, particularly bypass procedures, work by additional mechanisms. For example, it's been noted for many years that even before patients leave the hospital after gastric bypass, they can be on pretty high doses of insulin and within 2 or 3 days leave the hospital on nothing and have sustainable normal glycemia. So before they've lost much weight. Okay? So that's one observation that suggests that there's something else going on. There are numerous other studies that have compared patients who are losing weight, control group, at the same rate as gastric bypass patients in the first month or so after the surgery, but yet, for the same amount of weight loss, those that have gastric bypass have superior improvement in oral glucose tolerance curves. Now, I want to take a moment and brag about some of my attendings here, because this connection between bariatric surgery and some of the mechanism, particularly the role of the gut, one of the first investigators to show a link was right here, Ken Cyrynek. Let me go to this study right here. Alterations in gut hormones after Roux-en-Y gastric bypass may explain the anti-diabetic effect. And Arthur McPhee was also involved with that. This is one of the first studies to evaluate the change in gut hormones after Roux-en-Y gastric bypass. It was a relatively small study, 12 patients. Patients had oral glucose tolerance tests after gastric bypass. And by the way, that's not such an easy feat to accomplish. These folks get severe dumping, and they often are very mad. I don't know how you guys talked them into doing that. But they gave them oral glucose tolerance loads, and they measured some key elements: fasting glucose, insulin, gastrointestinal peptide, which is an important gut peptide, and found that these were dramatically reduced at the fasting level after surgery, and the area under the curve for the glucose tolerance showed also a significant decrease. Okay. Now, there's some other studies that have sort of showed that GIP actually may be increased in certain circumstances, and there's a debate going on about that. But nevertheless, this is one of the first studies to actually look at the effect of these operations on gut peptides. A few years later, another notable surgeon, Harvey Sugarman, and John Kellum at Medical College of Virginia were one of the first to show that another important gut hormone, at the time it was called enteroglucagon, it's now called GLP-1, dramatically increased in response to a meal after gastric bypass. You can see the post-op levels compared to the pre-op levels. And the other procedure they studied was the vertical banded gastroplasty, which had very little effect on GLP-1. And this is now known to be one of the most potent gut peptides or incretins that stimulates the beta cell to produce insulin. And many believe that this, there's data to support this, which I can't go into because of time, that this is probably a major factor with gastric bypass. And exactly how the mechanism of how GLP-1 is stimulated after surgery is not completely understood, whether it's a factor of bypassing the duodenum, or whether it is the fact that nutrients are getting to the terminal ileum quicker, because that's where GLP is produced by L cells in the terminal ileum. It's not quite clear, but a number of studies consistently show in response to a meal, GLP-1 skyrockets, and insulin secretion is dramatically enhanced with gastric bypass compared to the non-bypass procedures. That's a clue. So this is really interesting work. And for you youngsters out there looking for interesting things to jump onto, I mean, this is really hot stuff. And this is kind of an example of almost reverse research. You know, normally it's, it's bench to bedside. You come up with an idea, work it in the lab, you take it to the bedside. This is the opposite. We observed in a clinical procedure effect, and then we take it back to the bench. And here's an example we're trying to do in Cleveland. We have a metabolic basic science laboratory. I've been lucky enough to work with some phenomenal investigators and researchers, one of which is Sangeeta Kashyap, who is a trainee of Ralph's, a phenomenal, bright lady, collaborating together with our endocrinologist to figure out how these operations work. And using a rat model, using a gastric bypass rat model, with this rat model you can, we've realized with this surgery we're probably doing a lot of different things, and remember Arthur used to say, surgery is just manipulating anatomy to create a physiologic effect. Right, Arthur? Remember you telling us that over and over again, and that's what it is. But we're probably manipulating the anatomy in a lot of different ways with the surgery. So with the rat model, you can isolate. You can vary the size of the gastric pouch. You can vary the amount of duodenum or gut that you're bypassing, and you can critically look at these animals, and you can do invasive things on them you can't do in humans to get at the models. And you can grind up the pancreas. We have a model where we grind up the beta cells up in vitro, and we stimulate the beta cells after these procedures and measure insulin secretion. And we found in a rat model that after gastric bypass, when you stimulate the beta cells with glucose, the insulin production, is dramatically greater than sham-controlled animals. So this is just one example of going from the bedside to the bench to try to understand how these operations work. Now, as I begin to close here, the quintessential question is, what is the role of surgery for treating diabetes? International Diabetes Federation, which is a global organization, it's kind of like the ADA, but it has a sort of global perspective on this thing, published a very detailed review and guidelines, and basically came up with these statements, which are pretty favorable, basically saying that if an individual's got severe obesity and type 2 diabetes, particularly if it's not well controlled, they should really go to surgery after you've exhausted the reasonable medical strategies. But they go one step further and even talk about BMI 30 to 35, people who are just modestly overweight, okay, which is probably about half of us in this room, who have diabetes. They may be candidates for surgery as well. Okay, and this is a new step forward. And depending upon your ethnic group, for Asians tend to have high percent body fat for a given BMI. So even for Asians, they suggest maybe even going as low as BMI 27.5. So a major step forward. Now, with all this data I've showed you, why is surgery underutilized? Okay, the answer may be, where are the randomized controlled trials? Because after all, in medicine today, what changes behavior, the randomized controlled trials, when you're comparing apples to apples with prospective studies, where you have pre-specified endpoints that are carefully evaluated to eliminate the bias, right? Well, let me just share with you. There's 3 randomized trials, and 2 are brand new as of about a week ago. So this is the first one. This was gastric banding, BMI less than 35, published in JAMA in 2008. Involved early diabetes. Patients on average had diabetes less than 2 years. The A1C was 7.7. None of them were on insulin. Randomized to gastric banding versus medical treatment with an emphasis on medical weight loss. And you can see the BMI went as low as 30 on these. Bottom line, there was a 73% remission. Patients achieved A1C of 6% or less. In the surgical group, only 13% in the medical group. Most of this, of course, is driven by the weight loss, and fortunately no serious side effects in this group, but a very small study. Let me just share with you 2 other studies. This is a study that we accomplished, and this is a multidisciplinary effort at the Cleveland Clinic with endocrinologist Sangeeta Kashyap is my colleague, who was trained here years ago, cardiologist Steve Nissen, Deepak Bhatt, a number of other investigators, basic scientists, and so forth. This was published online March 26 and published in print last week. And this is a 3-arm study. 150 patients randomized to 3 different groups. One was intense medical therapy. The other was medical therapy plus gastric bypass. The other was medical therapy plus sleeve gastrectomy. The inclusion criteria, you had to have diabetes. A1C had to be greater than 7. BMI between 27 and 43. Age between 20 and 60. And at the time of analysis, which was 12 months after the intervention, we had 93% retention. We lost a few folks in the medical arm. 7 of them immediately withdrew after randomization, unfortunately. Then we had 2 that missed their 9 and 12-month visits. Okay. And this shows you their baseline characteristics. To make a long story short, these were folks that had fairly advanced diabetes. They had diabetes for an average of greater than 8 years. Their average A1C was about 9 or greater. Body mass index was 36. About 36% of them had a BMI less than 35. They were on a ton of medications. Most were on at least 3 anti-diabetic medications. This is at the start of the study, okay? Almost half were on insulin, and they were on lipid-lowering agents and antihypertensive agents. These were folks that were highly medicated prior to entering the study, and they were in poor control on medications. These are very refractory patients, by and large. And here's our primary endpoints. The top line shows the primary endpoint, and the goal was to get as many patients as possible in all three groups to normal glycemic control, an A1C of 6% or less, regardless of the medications that they were on, okay? So 12% achieved that in the medical group, 3 or 4 times that number achieved it in the bypass and the sleeve group. Now, interestingly, in the bypass group, all 42% that met this target did so without medications. They were completely weaned off all their medications, okay? So they went from 9% A1C to 6% without drugs. And then not quite as many in the sleeve gastrectomy, 27% reached that target without drugs. And you can see the others, dramatic changes in fasting blood sugar, the body mass index dropped by about 10 points in the surgical group. We were elated to see that in the medical group, they did lose some weight, an average of about 5 kilograms. We saw improvements in HDL, triglycerides. The total cholesterol did not change. They all were on statins preoperatively, and statins are actually fairly effective for total cholesterol. C-reactive protein, a good marker of cardiovascular risk, dramatically decreased in the surgical group. We did not see a change in blood pressure. These folks are all fairly well controlled with blood pressure medication. In the next few slides, I'll show you the time change. This shows you the very rapid change in A1C after the 2 surgical procedures. In the medical group, they did improve. And keep in mind, that these folks were highly medicated at the start of the study, and they were poorly controlled. So Dr. Kashyap aggressively managed them. She switched them from insulin to GLP-1 agonists. Ralph, you're proud of that, all right? Much more effective drugs. And they got better, but at 6 months. And then they started to recur a little bit there, okay? Even though that we're continuing to intensively treat them. Change in body mass index, no surprise here. But notice how the change in body mass index is more gradual, but the change in A1C is very rapid. A hint that maybe it's not just weight loss driving all this, right? This shows you the change in average number of diabetes medications, okay? A slight increase in the medical group, but what was really happening was she was trying to get them off the insulin and on to more effective GLP-1 agonist type drugs. And in the surgical group, particularly gastric bypass, almost all of them were off, or a high percentage were off most of their antidiabetic medications. In the surgical group also, almost all of them got off insulin, whereas still a high percentage of patients in the medical group still required insulin to maintain their control. And this shows you the change in cardiovascular medications. Again, at the start of the study, at baseline, most of the patients were on greater than 3 drugs. And at 12 months, most of the surgical patients were on either 0 or just 1 cardiovascular drug, while most of the medical patients were still on at least 3 or more cardiovascular drugs. I'm talking about antihypertensives, statins, diuretics, calcium channel blockers, beta blockers, so forth. Here's the adverse events. No surprises here. There were no deaths, fortunately, no major complications that result in disability. There were 4 patients in the surgical group, 4% that required reoperation that resolved the problems. And so the summary of this study is that basically surgery was more effective than medical therapy by a wide margin. And in glycemic control, it also improved major cardiovascular risk factors, and it also reduced their medical burden. I'll just show you another study that was published in the same issue of New England Journal of Medicine. I'll conclude here in just a minute. That basically, very, very similar data. This was in a group of severely obese patients, the very same issue, and they showed this was conventional medical therapy versus gastric bypass versus venopancreatic diversion. This is A1C control, and you can see, again, superior improvement. This is also a randomized trial. So now 3 studies. So I would submit to you that, perhaps what this is suggesting is that we need to change the paradigm and probably consider surgery earlier, before the beta cells are gone, before it's too late, because that may be the window of opportunity to really alter the natural progression. And I would submit to you that this strategy is very complex and probably just not applicable, not feasible. And this probably is what we should be doing. And Ralph, I will give you a copy of this algorithm so that you can share with your colleagues throughout the country. Finally, I just want to thank my colleagues in Cleveland, phenomenal surgeons and bariatricians, and we have a wonderful team of support individuals. And so the last big thing is peptic ulcer surgery. The next big thing is metabolic surgery. Thank you so much for your time.
Questions for Dr. Schauer?
Phil, what about children? You know, they've talked about doing bariatric procedures and sound like Calvinists, but, you know, that sometimes they're preordained by age 6 or 10 with fat cells that they're going to get into trouble. What is the outlook on children right now?
It's been done carefully. You know, pediatricians are kind of a nervous lot, and you can imagine. But you're right. I mean, if a kid is obese, severely obese as a teenager, the probability that they will be severely obese as an adult is like close to 100%. And you know, we've seen kids. You know, our youngest is a 12-year-old who was 400 pounds. Okay, so I mean, there's no medical therapy that's going to make an impact. So yes, and there are a number of groups. The NIH is studying this. I think we're going to see this gradually increase over time. We have to be very careful. There's issues about, you know, growth and stunting their growth, but I mean, to me, those issues pale in comparison, you know, to a kid who's got this metabolic burden in his teenage years, and by the time he's 30 or 40, he's going to be having a stroke or a heart attack, right, Ralph? So, I mean, the punishment needs to fit the crime. That's what I was always taught in surgical residency, right? So, when they've got severe disease, then you need to have a solution that works. Yeah, I think you need to hold it down.
Hold it down. Got it. I want to make a comment about the fact that the study that you didn't make was that the sleeve part of this study is really new data and may go a long way to getting us to get CMS to start approving sleeve for patients. Could you comment on what dietary intervention was done in your study? I know that she was very aggressive with medications, but what kind of counseling were they given on dietary?
And the folks on the medical side got much more dietary intervention. They were seen by the endocrinologist at least every 3 months, and often in between with phone calls from diabetes educators. They followed all the ADA guidelines. They were encouraged to join Weight Watchers. I mean, they were counseled, but they ultimately were left to do the things that they were supposed to do. And so there's always going to be compliance issues with medical strategy, whether it's taking a pill or whether it's exercising or being on a diet. And I think that's the problem with the medical strategy is it relies on compliance, and we know that compliance is a big problem. Carlos, yes.
A comment rather than a question. You show the dramatic disappearance of peptic ulcer surgery. The very same thing is going to happen to this. This is not meant to be.
My kids have to graduate from college first. Then it can go away. I got to pay off the mortgage first.
Patients you're helping right now need help right now. They cannot wait for the miracle to come along. The miracle will come along. Because the problem is somewhere in the brain. It's the appetite center, the feeling your stomach full or whatever. And you're messing up the perfectly normal GI tract.
Right. It's not the gut's fault. It's not the stomach's fault. Yeah. Well, it's a great comment. But Professor Pestana, I will hasten to point out, obesity is many, many times more complex than peptic ulcer disease. Okay, and the pharmacology, H2 blockers, it took them 3 decades to develop H2 blockers, and PPIs took another decade or 2. Okay, all that does is it's a proton pump. It's a very simple system. Okay, obesity is very complex, and the drugs have failed and failed. The last 10 drugs introduced have all been wiped off. They don't work. So it's a very complex problem because there's multiple integrated pathways. If you block one pathway with one pill, another one picks up. So it is a complex problem. So I think it's going to take a while. I really do. And you know what? But I think surgery is a model. If we figure out how the operation works, then we're going to be able to have a much more effective therapy. Don't you agree, Ralph? Yeah. Ralph, do you have any comments? You've been really quiet.
I basically agree. I think that if you have major cardiovascular issues or major morbid conditions, irrespective of what the BMI is, I think you really ought to consider surgery. In fact, I recently had a lady who works here at the Health Science Center, and she came to me with a 17-year-old kid who was markedly overweight, had sleep apnea, and in fact, she had to answer all the questions. He kept falling asleep. And I suggested that the kid have surgery, and she didn't want to do it. And 6 weeks later, she called me in tears because the kid died in his sleep. So to come back to the question about pediatric surgery, I think when you have morbid conditions, then I think, of course, it's a no-brainer. And I think that the IDF statement is a very important one about moving forward and lowering the BMI. And I think particularly if you've had people who've tried to lose weight, gain weight, lose weight, we see these people all the time, and then they're going through progressive therapies, and they get to a choice of having to go on to insulin, and then I think it becomes like a no-brainer. I think the real issue is, when do you start early on?
I think insulin is a tipping point.
From my standpoint, insulin is very difficult for patients, and particularly overweight patients, large doses. It's not an easy drug to use. Very few people really get an A1C less than 7.
Right?
They gain weight, they get hypoglycemia. So I think that, to me, this is a critical point. And for patients who really get to this point, hopefully they don't get to this point. And so now in terms of etiology, I think GLP-1 is crucial. And I said to Mohammed, it's really an embarrassment for the endocrine community when a surgeon understands better the importance of beta cell failure. And the endocrine people don't get it. So if you don't start early enough, and I totally disagree with the ADA algorithm. I mean, that's a doom. And the ADA is very conservative, so things don't move very quickly. And I think that's part of the reason why bariatric surgery hasn't been adopted. But to me, you need to preserve beta cell function. That means starting early at the pre-diabetic stage. And the drugs that I think work best are the GLP-1 analogs in combination with the TZDs. And those are the drugs which are also very expensive. And those are also the drugs that the American Diabetes Association doesn't push. They push metformin and sulfonylureas. And evidence-based medicine says those drugs don't work. And when we talk later, I think we probably both agree that GLP-1 is a critical hormone here. And basically what you're doing is taking sort of a disease which is pathophysiologic, where they don't make enough GLP-1 and you don't respond, and then we're doing something with the gut. We're actually creating another pathophysiologic disorder.
Right.
We're jacking up the GLP-1 levels to astronomical levels. So we're treating a pathologic disease with a pathophysiologic intervention, but the two work very well, and clearly the data are, I mean, there's nothing that you're going to see do what you show. And again, congratulations on, showing in a very well-designed prospective trial that this works, because now maybe the ADA and these other organizations that want evidence-based medicine will get with it, because now there is evidence-based medicine.
Right. Well, thanks for those comments. And all this, medicine versus surgery, and that's all tongue-in-cheek, right? It's fun for discussion, but it's really it's time to work together, right? And that's what we're trying to do in Cleveland. We have an institute now that includes endocrinologists, metabolic surgeons, endocrine surgeons, trying to work together to figure out the best therapy, whatever it is, And hopefully, going forward, a collaborative effort is where to go, I think. But thanks for your comments. Basil.
Thank you for that nice presentation. A couple of questions. Are any of these changes that you notice, particularly in the NASH patients, accompanied by change in metabolic rate and particularly RQs, which would indicate a different preferential fuel source? Secondly, Dr. Herndon presented that paper that propranolol reduces central fat accumulation in hypermetabolic patients. Would propranolol have a synergistic effect with your operative procedures?
It's a great question. And the clinical literature is mixed on that. There's a couple studies that show that the basic metabolic rate does change. It actually increases after these procedures. A couple studies that show it doesn't. And there's a couple rat studies that suggest maybe it's truly Kaplan out of Harvard. It's done some nice work showing increased metabolic rate after these operations. This maybe may help explain this long-term sustained weight loss. You're jacking up the metabolic rate. So that's another ripe area for investigation. I don't think we've answered that question yet.
Since the early 80s, I learned in a graduate level neuropsychology course that in rats, there's a satiety center and a hunger center, and you can just take a little probe and ablate the satiety center or the hunger center, and they'll eat till they die or they'll starve till they die. And I've always thought that this whole disease process was going to be the domain of the neuroradiologist, where you have an outpatient partial ablation.
Well, two comments about that.
And at that time, they were moving to primate studies.
Right.
This is 1983 or
Right.
so, and I haven't heard anything about it in the last 30 years. And
Definitely
I'm wondering
work on this, yeah.
What's happening?
Well, and what we're learning is the gut talks to the brain, okay? You can manipulate the gut, or you can manipulate the brain, okay? Now, there's some work on this deep brain stimulation, okay? But it's one thing to, rearrange your intestines, but to stick a probe in your brain and to go through, wipe out 1965 and wipe out 1980 and wipe out the cerebral cortex to get to the hypothalamus, the risk of injury and consequences are pretty enormous. So there's definitely work in this area. And also figuring out, the problem is with these rat studies, you wipe out a certain part of the hypothalamus, they die. They just stop eating. So, you're trying to figure out exactly what cells to wipe out is big question. But there's definitely some work. There was a guy at the Cleveland Clinic that was working on that, deep brain stimulation. Ali Razai, who just recently left and went to Ohio State. But that may be. And even neuropharmacology may be the answer.
In the randomized trials that you mentioned, it'd be nice to have mortality data because that's the bottom line. But the question is, in the Swedish population statistics that you showed, it takes at least 6 years to see the effect on mortality. So are you planning on following these patients long-term?
Yeah, our study we are. Again, we only have 150 patients, so it's not powered enough to see mortality differences. However, we are going to look at some of these other secondary complications. So we're tracking renal failure or renal function. We're tracking retinal changes, and we're doing a very meticulous retinal exams, and we think we might show a difference in retinal changes. Renal function, we're tracking neuropathy, which is kind of hard to measure. We're probably not going to see a clinical event difference in these with 150 patients, 50 in each arm. We're looking at carotid IMT. We're doing DEXA studies and body composition. So we're basically dependent upon surrogate markers. What we really need to do, Ralph, is we need to convince NIH and IDDK and HLBI to do the definitive major clinical trial. It costs several $100 million.
Yeah, I don't want to sound unscientific, but I think the data are so impressive from the SOS study. For people to argue that that mortality and morbidity are not benefited, sometimes you have to go on the best evidence, and the fact is, to get these kind of data, you got to do a 10-year study, and to do a 10-year or at least a 6-year study.
Right.
To do this would require, as you pointed out, the NIH. Who's going to do this?
Yeah.
Exactly. But I think the data are pretty clear. On short term, the 3 studies are pretty conclusive, and I think the SOS study.
But you're an outsider compared to your colleagues. Many of your colleagues, say they don't believe this data. Even these recently published studies, is biased and it's not blinded and there's no sham surgery and they want these. Can you imagine a sham gastric bypass? Yeah. I presented at the American College of Cardiology. I was questioned, why didn't you do a sham control? What? But so your colleagues are saying, until we have a multi-center randomized controlled trial, this data means nothing.
Yeah, but
the problem is this has been underutilized for several decades. We've got to sort of move this field forward.
Remember, I'm the guy at the Banting lecture in 2008 who got up and denounced the ADA algorithm for treatment of type 2 diabetes. So they are my colleagues.
Like you, Ralph.
Yes.
For sure. The questions are...
So the big question is, the payers are what really control. At this point, you're preaching to the choir, right? So most of us buy into it and believe it, but it's not up to us. Ultimately, either the patient has to pay for it themselves, which most patients don't have $25,000 in cash laying around the bank account to pay for this. Some do, clearly, and are willing to do it. But, you publish a paper on the sleeve to show that it has comparable weight loss to the bypass. But I just have you seen the needle move at all in terms of?
It hasn't moved that much. You know, it's been a challenge. This has been 5-10 years in progress where thinkers have been really trying to move things forward. The International Diabetes Federation published a year and a half ago. Didn't see much change there. A couple randomized trials. You know, the payers and hiding behind this archaic notion of obesity as a self-inflicted psychological problem where the patient deserves not to be treated, okay? And even a lot of doctors think that way, believe it or not, a lot of doctors, okay? That's part of the problem. And this other notion that, you know, until there's multiple randomized controlled trials, the observational data, no matter how consistent, no matter how large the treatment effect, they don't mean a hill of beans until you have a randomized controlled trial. So that's what a lot of these sort of payers are sort of hiding behind that notion. But maybe we're going to see things move now. I mean, these two studies published in New England Journal, it's a huge impact internationally, that journal. They both corroborate each other. So perhaps we'll see the needle move forward.
Phil, maybe we can't convince them metabolically, but financially. There are studies now that show the break-even is somewhere between 18 and 24 months financially, between treating the diabetes and then the cost of the bypass.
And that's probably the most perplexing thing, Ken, because you know, the prejudice and ignorance aside, if you just look at the cost of treating disease, here's an astounding fact. This is a paper presented at ADA a couple years ago. The average cost to treat diabetes, individual diagnosed at age 50, is about $175,000 lifetime cost. Individual diagnosed at age 30 is over $300,000 for one person. When you add up all the medications, when you add up all the treatment costs, the complications, it's a very expensive disease. Gastric bypass is $25,000. Now, albeit we're not going to cure everybody, and we're not going to completely wipe the disease out, but probably we're going to reduce those long-term costs quite a bit. And you're right, the payoff is somewhere 3 to 5 years after the procedure. About 10 studies sort of corroborate that.
Dr. Schauer, thank you so much. This is a phenomenal talk. I appreciate it because it highlights what we've seen. You've been talking about this at the ASMBS for years, and so to see it actually come out in paper and then everybody all excited about it with the popular media talking about it, it's awesome. I would say that I really want to figure out a way to get the people to get this to be more proactive than reactive. And I'm in the reactive stage still where, and luckily here we have someone who does care and sees it differently. But we have this idea that obesity is only the 400-pounder. The doctors are not seeing the BMI of 35 as a problem.
Yeah.
And they send me the diabetic who's on 300 units of insulin a day, who, by the way, which was the worst one I've had so far, and he actually was off his insulin in the hospital and now is at 100 units every 3 days. So it's huge, and I'd rather get the guy who comes in kind of uncontrolled on medications, and as soon as we do it, he's off, and doesn't have to worry about compliance because he's doing great. And so that really highlights. How do you get out there and change that?
Yeah, I mean, first we're going to see. I mean, it's a new thing. We have to remember, we surgeons have to be patient. Look, diabetes for 100 years since insulin was discovered by Banting and Best. And I'll hasten to add that Banting was a surgeon. Ralph, orthopedic surgeon, okay, discovered insulin. And one can argue the two most important contributions to treating diabetes have been from surgeons. Discovery of insulin and metabolic surgery. But all kidding aside, no, what we're likely, sorry Ralph, had to do it. No, all kidding aside, what we're going to see first, the endocrinologists are going to send us the real sick folks first. I mean, that's just natural, right? And it may be, I'm not saying it's too late for them, because we're probably going to be improving them. But I think the real opportunity, as I showed that one slide, and as Ralph was saying, it's all about preserving the beta cells and being aggressive early, and being aggressive with lifestyle and exercise early, and drugs early. And for those, and perhaps if we do that early enough, a lot of folks won't need surgery, right? But when they reach a certain point where they become uncontrolled on medication, a reasonable number of medications, then go to surgery. That may be the best indication. But we're not going to see those for a while. We're going to see the folks who are 8-10 years out, who already have complications of their disease, who are horribly controlled. So finally, let me just close by saying it's been great. Appreciate the opportunity to be here. This surgery is exciting. I'll just point out this operation has a dramatic effect on individuals. I've talked about all the health effects, but just the quality of life is truly amazing. And I'll point out, I'm not going to point out this person in the room, but there's a person in this room who's had this surgery, and I guarantee you that this person is one of the most healthiest persons in this room. And the operation was done 8 years or so ago, and this person is doing extremely well, and none of you will be able to pick this person out in the room. Okay? Yeah, Wayne. Remember when Wayne took a week out? Thanks so much, folks. It's been a pleasure. Okay?